So welcome all and let's start this session. I'm Dr. Ankit, your anatomy faculty in our LN Next, and these are the Yield MCQs for our FMGE aspirants. And make sure that if you go through these MCQs and these topics, most of the questions of the anatomy will be solved. So that's a very Yield and just few days left for the exam. So before going to the session, all the best from my side for the exams. And let's do this Yield from the anatomy. Let's start. First question over here. The physician exacerbates, means increases the wrist pain by applying pressure to the base of the thumb as seen in the photo. You can see the pic over here, and here we have increase the pain. The imaging will confirm a break of which carpal bone. So if you look over here in the thumb, then the thumb sides is radial or the lateral side. So we have some problem in the lateral aspect, and lateral carpals would be affected. So if you know the mnemonic, what are the lateral carpals and the medial carpals? So here if we go from say lateral to medial, proximal row, well, the mnemonic we all should be remembering them. She looks too pretty, try to catch her. Then this S is the scaphoid, then comes the lunate, then you have triquetral, then the speciform, then we have the trapezium, then we have the trapezoid, capitate and hamate, right? Therefore the lateral carpals are these carpals, scaphoid and trapezium, and we all know that the most common carpal to be fractured is a scaphoid. Actually, that's quite common. So therefore, if we have the option like a scaphoid, that should be our best bet, and therefore this is the answer in this particular question, the scaphoid. So pressure to the base of the thumb, lateral side, confirm a break of which carpal bone? Normally it is scaphoid, that is frequently fractured. So remember, this is the location of the carpals. So the topic is carpals. Remember over here, what questions have they asked? There are two topics they asked is regarding the ossification of carpals. That is very important. And pisiform, we all know it's a sesamoid bone. Pisiform is a sesamoid bone, and it develops last around 9 to 12, or some book says 10 to 12 years of age. Okay. Now the direction of the carpals in which they are going to be what we can say is ossify. To start with, this is a capitate, then you have the hamate, let me put a different arrow, then we have the triquetral, then lunate, then scaphoid, then trapezium, then trapezoid, and finally we have this pisiform that comes. So if you go anti-clockwise, to start with capitate, that ossifies around the first year, then subsequent years, second year, third year, fourth year, fifth year, sixth year, so around 6 to 7 years they all ossify except the pisiform. It will ossify last because it's a sesamoid bone formed in the tendon of flexor carpi ulnaris. Okay, so remember these basic points of carpals they are asked. Let's see the next one. Here again a question from the upper limb. 26-year-old lady comes to the physician for a follow-up examination 1 week after undergoing rotator cuff repair surgery. Surgery is for the rotator cuff. Rotator cuff, we all should know the muscles over here are SITS, small t and s, supra-infraspinatus, teres minor and subscapularis. And most commonly rotator cuff repair surgery or most commonly tendon damaged over here is our supraspinatus. This we should come to the back of mind. Next time, physical examination of the right shoulder shows a decreased sensation to pinprick and light touch over the lateral shoulder. So here on the lateral part of the shoulder, there is decreased sensations. So this part, if you remember, the lateral cutaneous nerve of arm. In the arm, we have the axillary nerve at the upper part and the radial nerve at the lower part. In the lateral part of the arm or the lateral part of the shoulder, we have this axillary nerve over here. This information you should know. This normal passive range of motion of the shoulder, but she has difficulty externally rotating, that is lateral rotation, and abducting the arm. External rotation of the arm, LRTI is the mnemonic. LRTI is what? Lateral rotation. T is teres minor, and I is infraspinatus. And abducting the right arm. Abduction is basically supraspinatus and deltoid. So abduction is basically, if you put an arrow over here, abduction is basically two muscles you have to keep in mind. One is a supraspinatus and one is a deltoid. Okay, now which of the following structures most likely injured? Now we have see that it was a rotator cuff repair surgery. Could have been involvement of the supraspinatus. Could have been. According to sensory loss, looks close to the for the axillary. Now we can think of axillary now if we look at the sensory loss. If you look at the muscles, which is weakened is lateral rotation and abduction. On lateral rotation, we have teres minor, abduction, we have deltoid. Both of them are again supplied by axillary nerve. Therefore, answer is 100% over here. the axillary nerve, option number B over here. So look at the sensory findings, look at the motor findings, try to join them, and look at the surgery. Surgery was done at the rotator cuff. Where is axillary nerve? Around the surgical neck of humerus. So location also. Everything pointing out to the answer, that is axillary nerve over here. Upper trunk, lower trunk, the trunk is located where at the triangles of the neck. The long thoracic nerve is basically running on the medial wall of axilla. So that is quite far away from the rotator cuff region. Okay, therefore answer is this. Let's see the next one. While walking to his classroom building, a first-year medical student slipped on the wet pavement and fell against the curb, injuring his right arm. So there's injury to the right arm. Images shows a mid-shaft fracture of the humerus. Which pair of structures was most likely injured? Always do remember that with the humerus, there are three structures or three nerves which are commonly injured. One is if there is problem in the surgical neck of humerus, think of axillary nerve. If there is problem in the mid-shaft of humerus, think of radial nerve lying in the radial groove. If there is problem in the medial epicondyle, think of what? Think of the ulnar nerve. Now, with the radial nerve, there is also one other structure that goes around, is a profunda brachii vessel. Profunda brachii vessel. These are the contents of the radial groove. They both pass in the radial groove. Now, the question they are saying mid-shaft fracture, obviously it has to be somewhat radial nerve and profunda brachii. If you look at the options, then obviously we have the option number C over here. Profunda brachii, also known as the deep brachial artery. Profunda means something lying deep. If you look at the other options, median nerve and brachial artery. Again, median nerve and brachial artery are, no doubt, they are located over there. But median nerve or the brachial artery are not in contact with the bone over here. They are in the, no doubt about it. Axillary nerve and posterior circumflex humerus, they are again at the surgical neck region. Suprascapular nerve and artery, again, they will be lying at the top of the shoulder, behind the clavicle. So, considering this, the answer is option number C. Right. Let's see the next one. Which nerve has a shaded cutaneous territory? Now look at the cutaneous territory over here. First of all, it's a palmar or the dorsal aspect. If you look at the nails, we know it is a dorsal aspect. Point number one. Then there's a thumb, so it is lateral, that is medial. We are dealing in the lateral part of the dorsum of the hand. And lateral, how many? 1, 2, 3.5 digits. Excluding this, you can say the distal phalanx and the nail bed region over here. This all is supplied by superficial branch of radial nerve. What is this branch? Superficial branch of radial nerve. Is this area. Now, this area over here will be the area of ulnar nerve. And these fingers over here, they are under the cutaneous territory of median nerve. So therefore, superficial branch of radial nerve or simply radial nerve, if they are given, that is also a good answer. Looking at over here, the other options. Ulnar median, we have seen posterior interosseous is a pure motor nerve. It supplies the extensors of forearm. So no need to worry about it. The hand cutaneous supply, they come a lot. So you've seen this question, hand cutaneous supply, the topic over here. Here, again, the injury. See, upper limb or the lower limb, the injuries, the joints, they are important. They are the ones which are injured, which are the clinical cases over here. In previous question, we talked about again this rotator cuff repair, that is also quite common. Scaphoid fracture. These are the common questions. Let's see one more over here after this. Look at the bone over here. Now that's a pure anatomical question. What are they asking you? The muscle attached to the area marked in the figure below. What is the muscle attached over here? First, you have to identify that this is a part of the humerus. You can see this is the olecranon process. Therefore, this is ulna, ulna. Therefore, this is automatically our radius over here. This becomes the radius over here. You can also see this radial head over here, the head of radius. This swelling over here will be what? It is a part of the radius. Which part of the radius it is? It is just below the head of radius. This will be the radial tuberosity. This basic anatomy. Now, even if you don't know the details of tuberosity or all, but you should identify the radius ulna humerus. That is must know. I hope all of us agree with that. Now look at the options. Biceps brachii. Biceps brachii attaches to the radial tuberosity. Therefore, this is the answer. What is how to remember it? Remember, biceps brachii is a flexor, important flexor, yes, flexor of forearm, but it is also important supinator. And supination is a movement occurring at the radius. It has to attach to radius. Brachialis is attached to ulna. This was radius. Brachioradialis will start from the lateral supracondyle line to go to the lower end of radius, not the upper end. So therefore, this also rules out. Triceps are going to the olecranon, this also rules out. Therefore, answer is option number A. Sometimes try to rule out the other options. Then we can actually come out to the correct answer. Now let's see in the question over here, which of the following nerves are related to the marked structure? First of all, identify the bone. I hope there's no problem identifying the bone. Bone is a hip bone. inner surface or outer surface? We are seeing an acetabulum, no. So it is the inner surface or the pelvic surface of the hip bone. You can see the ischial spine posteriorly where the arrow is pointed out. So this is the ischium located posteriorly. Therefore, this is the right hip bone. This is the anterior aspect. Ischial spine. Now they ask me what nerve is related over here. Now what is this over here? This over here is the greater sciatic notch. Greater. That below is the lesser sciatic notch. This was the greater sciatic notch. Now see, remember over here that behind this, there were a couple of nerves or a nerve that passes behind it. It enters from here and then it passes, just a second, this is the nerve that is coming from the sacral plexus, right? And then it goes where? It goes behind this ischial spine and then it again comes into the perineum over here. Which nerve is this? This nerve over here is the pudendal nerve. This is the pudendal nerve over here. And this is the region where we give the pudendal nerve block. Therefore, the nerve that is closest to this area should be the pudendal, and that should be one of the options. Also, remember the clinical aspect is a pudendal nerve block. How to give this block over here is given two ways. Either it can go transvaginally or go medial to the ischial tuberosity. Okay, and you have to inject the anesthesia to just block this nerve over here. Now look at the other option, the obturator nerve. Obturator nerve passes through the obturator foramen, and this would be the location of the obturator nerve coming from the L234 going down over here. Femoral nerve is more anterior, runs in the iliopsoas groove. It is more lying anteriorly. Sciatic nerve is quite a thick nerve that will be over here, but that is going posteriorly, not related to the ischial spine. It is just going below the piriformis, close to the ischial spine. But if pudendal is the option, then you have to go with this. Pudendal not in the option, then think of sciatic, right? Okay, so next question. A female fell in hospital and landed on her hip. Old age female. The X-ray shows fragmentation of her proximal femur. Which muscles is most likely detached in this fracture over here? Now have a look over here that you can see the femur over here. Okay, this is the head of femur. Then this area is the greater trochanter of femur. This is what? That is the greater trochanter of femur over here. That has been shadowed over here. Basically, we should know what are the muscles attached to the greater trochanter. So what happens is from the gluteal surface, the muscle comes and attaches over here like this. From the gluteal surface, the muscle comes and attaches over here. And when it contracts, it will make the whole lower limb out, away from the midline. That is causes abduction. So what are the muscles that causes abduction at the hip joint? They are the gluteus medius and they are the gluteus minimus, mainly these two muscles. And are they attached to greater trochanter? Answer is a big yes. Attached to greater trochanter, yes, on the lateral aspect. Are they one of the options? Let us see. Definitely option B is the answer over here. Gluteus maximus on the other hand is present basically posteriorly onto the gluteal tuberosity or the iliotibial tract, and it is causing extension. Iliopsoas is present anteriorly, that is to the lesser trochanter, causes flexion. Lesser trochanter will be slightly in this region, slightly posteriorly. Biceps femoris again is a hamstring muscle, goes down, inserts into fibula, comes from the ischial tuberosity, not related anywhere over here. So here the question was, can you identify the greater trochanter? If yes, you should know these two big muscles. And why are they important? The Trendelenburg test over here. Okay, when these muscles are not working, the superior gluteal nerve or the joint or the bone is fractured, whatever it is. So this test is also very, very important as comes as a question. So when the test is so important, we should know basically where this muscle is actually attaching to. I'm not saying every little detail of the bone, but at least big general features. Okay, this muscle is going from this gluteal surface of the hip bone to the greater trochanter of femur. That's it. Even that is enough. Okay, let's see the next one. While on a neurology rotation, the physician asks you to test a patient's femoral nerve function. Femoral nerve function is being asked to be tested. What would you do? A femoral nerve is a nerve with the root value of L2, L3, L4, supplies the anterior compartment of the thigh. The anterior compartment of the thigh is also known as the extensor of the thigh. But what does it extend? It extends the hip or the knee joint. It is going to extend, please remember, the knee joint. So what are the muscles basically over here? The muscles over here are basically the quadriceps femoris. And these are the main muscles which are causing the extension of the knee joint. So this whole femoral nerve is supplying the muscle which causes extension of the knee joint mainly, basically. Let's see if that is one of the options. Option number D, if you look, have the patient extend the knee against rotation, that would be the best bet over here, and that is the answer. Let us see other options as well. Have the patient flex the knee. This is done by the hamstrings. supplied by the tibial nerve. Have the patient rotate his thigh medially, medial rotation of the thigh done by again gluteus medius minimus. Have the patient extend the thigh against resistance, extension of the thigh, G-max, gluteus maximus. Okay, that is supplied by the inferior gluteal nerve, medial supplied by the superior gluteal nerve. So nerves and muscles. Femoral nerve, remember which compartment, that's enough. 45-year-old male, next question, is treated in hospital after he fell from bicycle. Examination reveals fracture of both tibia and fibula. Okay. On examination, there is foot drop present. Foot drop. Remember, foot drop, high stepping gait. It is due to paralysis of the muscles of the anterior leg compartment. Which muscle supplies them? Deep peroneal nerve. Do remember it. But normal eversion. Eversion is done by the lateral leg. Which muscles? Peroneus brevis longus. Which nerve supplies? Superficial peroneal nerve. That is okay. See, normal eversion. Which nerve is most likely injured? Foot drop is due to paralysis of the anterior leg muscles, which includes which muscles? Tibialis anterior we have extensor hallucis longus, extensor digitum longus. All these are causing dorsiflexion or extension of the foot. If you are not able to contract them, the foot will go to foot drop. There's a high steppage gait. And that answer over here is simply deep peroneal nerve. Now there is a small twist to the question. If they also say that there is foot drop and loss of eversion. Over here, if they put there is a loss of eversion, then we know that okay, it's a combination of deep and superficial peroneal nerve. We can think of common peroneal nerve injury at around the neck of fibula. So in this question, this would be the answer, but in other cases, the answer might differ. See the next one, a part of the physical examination, a physician asks the patient to stand on the toes. Standing on the toes, what nerve is the doctor testing? You ask the patient to stand on the toes. Look at think very, be total calm and relaxed. Think in a very logical manner. When you are standing on the toes, you are lifting your weight against the gravity. So basically, it's an anti-gravity movement, yes or no? The more the weight, the more power is needed, right? And look at which joint is moving. It is the ankle joint that is moving. What is the movement? It's a plantar flexion of the ankle or simply flexion of the ankle. So that is flexion of the ankle is done by which leg muscles? The posterior leg muscles, the calf muscles over here. And what is the nerve supply? The tibial nerve. So if you ask the patient to stand on toes, or you ask anyone, or you yourself stand on your toes, basically you are using your posterior leg or the calf muscle supplied by tibial nerve, and that should be the answer over here. If you look at the other options, deep peroneal, we have seen anterior leg, superficial lateral leg, and sural is a cutaneous branch of mainly the tibial nerve. Okay, let's see the other one. 7-day newborn, the diagnosis of PDA, patent ductus arteriosus, undergoes surgery to ligate the ductus arteriosus. We all know that this is the arch of aorta, and here you have the pulmonary trunk, right? And there's the left pulmonary artery, and you have the right pulmonary artery. Then from the left pulmonary artery, you have this small connection. That connection is known as in fetus, we call it as a ductus arteriosus, that normally should obliterate post-birth, that becomes ligamentum arteriosum. But here it was a patent over here. Now you're doing a surgery over here. The surgeon has to take special care to avoid a closely related nerve. The surgeon is protecting which nerve? Which nerve is related to this particular structure? That is the whole question. Now see, from the past 2-3 years, this question on this topic has come many times. If they show you a nerve going down like this nerve is the vagus nerve. Left vagus, not the vagus, not only vagus, left vagus. Why? Because arch of aorta, it is crossing arch of aorta laterally on the left side. Now from the left vagus nerve, here it gives up a branch that will ascend up. And this branch over here, it is the left recurrent laryngeal nerve. Question goes just below the arch of aorta and also goes below the ductus arteriosus. Okay, that was a frequently asked question. Therefore, the answer is over here is the left recurrent laryngeal, option number C over here. Option number C. Embryology is the reason behind why there's a different course. Okay, there's a different thing, but here remember the left vagus and the left recurrent laryngeal. It ascends up. Where will it go? It will go in the left tracheoesophageal groove. Tracheoesophageal groove. It passes. Let's see the next one. As a surgeon exploring the thorax, you will be able to identify the right pulmonary artery. Right pulmonary artery. Very good question. Very simple question. Where will you see the right pulmonary artery in relation to the ascending aorta and SVC? That is the question. Let us see over here. Let us start from behind. Most posteriorly, let us try to start from there. So most posteriorly, here is the what we can say as the esophagus going down. Nothing to worry over, just to show you this esophagus. In front of esophagus, what we have? In front of esophagus, we have this as a trachea, the tracheal rings, and then this trachea, it will bifurcate into the bronchi, right? In front of esophagus with the trachea. Okay, now see what happens over here is, here you have the pulmonary trunk also coming up. Pulmonary trunk, let me make it a bit darker over here. Okay, so this is the pulmonary trunk that is coming from the right ventricle and divides into left pulmonary artery and obviously the right pulmonary artery. Just think, it is lying in front. So you can see the relations of the pulmonary artery. This is the left pulmonary artery and that is the left bronchus. Same on the right side. Okay, now see what happens after this is, you have the arch of aorta. This pulmonary trunk lies in the concavity of arch of aorta. So here you have this as the part known as the arch of aorta. What is this? This is the arch. That is actually, imagine the 3D going from anterior to posterior, right to left. This part over here is the arch of aorta. So you can see where it is lying. It is looping over the left bronchus, and the pulmonary artery or pulmonary trunk is in the concavity of the arch of aorta. Okay, it's in the concavity. This is the arch of aorta, and this is pulmonary trunk is in the concavity of it. Now, last but not the least, here you have, if I may show with this color, here you have a vein that is coming down, and that is the superior vena cava, formed by this right and left brachiocephalic veins. So this is, imagine the SVC over here. SVC opens where? Into the right atrium. Right atrium is where is the right wall of the heart, anteriorly. So SVC is more anteriorly. So let me actually draw SVC in this manner. Here, this is the SVC. So it is lying more anteriorly, and behind it, this was the right pulmonary artery coming up from behind. This was the right pulmonary artery. So most posterior esophagus, then trachea, then the pulmonary artery bifurcates. In front of pulmonary artery, we have the aorta and SVC. If you come back to the options, they are asking you the right pulmonary artery. Look at over here, where is the location of right pulmonary artery? It is behind the aorta and the SVC. Is there any option posterior to? Yes. Option number D over here. Posterior to ascending aorta and SVC is the location of the right pulmonary artery. Understand, normal location of the right pulmonary artery is this. Very good question. 54-year-old lady is admitted to the hospital with a stab wound of the thoracic wall in the area of the right fourth costal cartilage. So we have the manubrium, we have the body, we have the xiphoid. We have numbering over here like the first, the second, on the right side, first, second, third, fourth, fifth, sixth, seventh, eighth, ninth, 10th. So if you number them, then this comes around the fourth over here. This is the fourth, right fourth costal cartilage. So there is a stab wound to the right fourth costal cartilage. A stab wound, if we put a cross over here, this is a stab wound. Which pulmonary structure is at this side? Understand over here the options. If you look at the options, horizontal fissure, it is horizontal fissure basically, and obviously of the right, can't be of the left, because the question also they are saying the right, so there's no point in thinking of left already ruled out. Apex is always at the top. So do remember over here that if you look at the lungs, if you look at the anterior view of this, say the right lung, okay, if anterior view of the right lung, then if I trace down the what we say is the oblique fissure, it starts from behind, like goes like this, then it comes anteriorly, and then it goes like this. This is the horizontal fissure. If you say some landmarks, posteriorly it starts around T3 spine or T4 vertebrae. In the mid-axillary plane over here, mid-axillary line or mid-axillary plane crosses around fifth rib or fifth intercostal space. Over here at the mid-clavicular line or plane, it reaches the sixth costal cartilage or the sixth rib. This is the oblique fissure. Which fissure? We are dealing with oblique fissure. But here the question was different. Yes, we are coming to it. We are coming to the horizontal fissure. Horizontal fissure present only on the right side, because right lung has 3 lobes, left lung has only oblique fissure, because that has only 2 lobes. So on the right side, we have from the fourth costal cartilage over here, we have a horizontal fissure going, meeting the oblique fissure at the mid-axillary line. So this is the area for fourth costal cartilage. And this is the horizontal fissure. And as they specifically said that this stabbing, the knife went to the right fourth costal cartilage, it is close to this horizontal fissure, and therefore option number B will be our best answer over here. Apex is always lying above, around 1 inch above the clavicle at the root of the neck. It is quite superior. 48-year-old lady had been scheduled for cholecystectomy. During the operation, the scissors accidentally entered the tissues immediately posterior to the epiploic foramen. Then there was a profuse bleeding. Which vessel was the source of bleeding? They are asking in a way the boundaries of epiploic foramen. First of all, let us deal with the epiploic foramen. Where exactly does it lie? So the region of epiploic foramen is, suppose this is the esophagus and the stomach over here. The lesser and the greater curvature, then the duodenum going around like this. Then imagine there is a liver over here. If you retract the liver, this is liver over here. Then imagine this is the lesser omentum going from lesser curvature and the first part duodenum to the inside of liver. So this is what that is the lesser omentum. I'm just writing L dot O M dot lesser omentum. Now if you see over here, then this right margin of lesser omentum. This right margin of lesser omentum over here. There is a gap behind the right margin. Where? Behind the right margin. So behind the right margin, we have a gap that is known as the epiploic foramen. That is known as the epiploic foramen. Behind the right margin it is. So understand this level is this. Now if we make a line over here, then which plane would it be? Passing through the pylorus. This is transpyloric plane. So this is your transpyloric plane over here. Transpyloric plane. Which is the vertebral level of what? L1, L2 junction, or around L1 we can say. Epiploic foramen is above it. So understand the region of epiploic foramen. I'm putting a couple of red arrows. It is behind the right margin of lesser omentum. Now come to the boundaries. What will be the various boundaries of the epiploic foramen? So what is lying boundaries of epiploic foramen, also known as foramen of Winslow? So what lies anteriorly? Anteriorly lies the portal tride. Why? Because these are the structures lying in the right margin of lesser omentum. Okay. What lies posteriorly? Posteriorly is the cause of question. There was bleeding. Posteriorly, there will be a retroperitoneal structure that would bleed. What is the major vessel retroperitoneally? IVC and aorta, which is on the right side, IVC. So posteriorly, we have IVC. And which vertebral level would be behind IVC? T12, because L1 was below. What lies superiorly is the liver. Which part of liver? Caudate part of the liver. Caudate process of liver. What lies below inferiorly is the first part of duodenum, D1. That lies inferiorly. So remember lesser omentum. Behind the right margin of lesser omentum, we have the epiploic foramen. And behind it, we have retroperitoneal. On the right side, which vessel? Bleeding. Question was bleeding. IVC. Therefore, the answer will be our IVC, option number B over here. Aorta is lying on the left side. Right? Portal vein is lying anteriorly. Renal artery will be slightly inferiorly. And retroperitoneal, but inferiorly. Right renal artery is good option. But it is lying inferiorly. Why? Because hilum of the right kidney lies around L2, L3. Okay, that is where the hilum of the right kidney lies, slightly below. So therefore, answer is option number B. Let's see the next question. Gastric contents exiting a posterior perforation of the stomach wall. There is a gastric ulcer and perforated posteriorly. So gastric content will accumulate which of the following? So here in the previous question, we have seen this lesser omentum and epiploic foramen. So what is this all structure lying behind? What is this space lying behind? That is known as lesser sac. And the space lying in front, over everything over here, that is greater sac. So basically we say the epiploic foramen is joining the greater with the lesser sac. The greater with the lesser sac is what the epiploic foramen is doing. The lesser sac is behind. Now if there is a posterior perforated ulcer over here and on the lesser curvature, it will perforate where? Posteriorly in the lesser sac. Lesser sac would be the answer, but the good point over here is that there is no lesser sac in the option. So do remember, lesser sac is also known as omental bursa. Hence, I guess that should be one of the options, and that is indeed option number D. That's the answer. Left paracolic, left paravertebral, right paravertebral, you can understand they are quite posteriorly. Paracolic is on the lateral side. Answer is our omental bursa or lesser sac. Lesser sac. Let's see the next one. You are at surgery and are about to mobilize the second portion of duodenum and the head of pancreas. Remember, here we have the first portion, second, third, and the fourth, right? And the pancreas lies in the concavity of the duodenum like this. This is how the pancreas duodenum lies. So you are mobilizing the second portion along the head. You note an artery and vein passing anterior to the uncinate process. This is the uncinate process. You see an artery vein passing in front of the uncinate and the third portion of duodenum. They are asking us, is there an artery going over here and there's a vein also going over here? Which vessel is this? That is the question. This vessel over here, the superior mesenteric vessels, we should know this. Other vessels of importance over here will be a vessel running over the superior border, that is the splenic artery. This will be the splenic artery. Another vessel of importance will be this superior mesenteric. This is superior mesenteric vein, that is superior mesenteric artery. The superior mesenteric will go behind the pancreas. From here, the splenic vein is coming. Which vein? The splenic vein is coming. It meet and they will form this vein behind, that is the portal vein. The portal vein will go above. Right, so these important vessels, remember 3-4 vessels around pancreas. Here the answer is superior mesenteric vessels. It goes in front of the third part duodenum. This is, imagine this is D3, that is D2, the small one is D1, and that was D4. And vertebral level are L2, L3, and above L1. That is quite a information, but all of questions have come from here only. Answer is option number A over here. 44-year-old admitted to the emergency with excessive vomiting and dehydration. Radio images demonstrate that a part of the bowel is being compressed between the abdominal aorta and the superior mesenteric, again superior mesenteric artery. Which part of bowel? I guess we already have seen it. So if you look at the lateral view, having this part being the anterior, this part being the posterior. And so therefore this will be the area for the aorta. And here you have a very small artery coming up known as celiac trunk. Below this you have what? Superior mesenteric artery. You've just seen it passes in front of which part of duodenum? The third part of duodenum. But there was also one more structure apart from this. What was the structure over here? That was the uncinate process of pancreas. And needless to say, there will be a vein also going over here. That will be the left renal vein. These are important structures. But here, as they're asking about the duodenum, we have to go with third part of duodenum. But apart from this, we have the uncinate process of pancreas also. That might or might not. But left renal vein is very important because it is draining not just the left part of kidney, it is also draining the left gonad and the left adrenals. Therefore, that becomes very important. Okay. So, therefore, 17th question answer is option number C. These relations are very common. They are commonly asked. Look at this face over here. What do you see on this face? A lot of vesicles being arise over here, which have already crusted also a lot. You see the question. A man presents with a shingles, a 7-year-old man. On the left forehead, left upper eyelid. And the bridge of the nose has shown which sensory ganglion is most likely. So here, if we look at the basics of the anatomy over here, the sensory supply of the face, this area over here is our territory of V1, ophthalmic. This territory of V2, lower eyelid and upper lip. And mandible over here below, we have the V3. So this is V1, but they are asking you which sensory ganglia. Obviously, this is a trigeminal nerve, so we should have a trigeminal ganglia. There's that trigeminal ganglia over here, the semillinear ganglia. Located near the apex of pituitary part of temporal bone, a very big ganglia. So therefore, it's what a straightforward question, but looking at the terms ganglia, people might get lost of what are they asking you. It might look very difficult question, but see, otic ganglia is a parasympathetic ganglia, parotid gland. Superior cervical is a sympathetic ganglia. There are 3 cervical sympathetic ganglia, superior, middle, inferior. Celiac ganglion again is parasympathetic. So what we are left with, we have to look for a sensory ganglia. This is the only sensory ganglia in the option. So go with it. Right, shingles over here is the case over here. 42-year-old lady complains to a physician about recurring episodes of sharp pain that seem to originate from around her mouth and cheek. Middle-aged lady. The pain is so intense that she is unable to eat, brush her teeth, or apply makeup. Which of the following cranial nerves is most likely the source of the pain? So there certainly is increased source of pain around the cheek. What is that? That is your tic, what we call it as doloru. Also the trigeminal neuralgia. Trigeminal neuralgia, sharp shooting pain, probably in the V3 or V2 nerve, and least involvement of V1. Sharp shooting pain around it. If it goes to the maxillary sinus, it's on V2. If it goes to the ear or the mandible, it is V3 involvement. Cause of it is unknown, but somehow it is said that the nerve is being compressed by some of the artery. Artery could be a branches of the basilar artery, could be superior cerebellar artery, might be compressing the trigeminal nerve, or could be the ICA branch of basilar. Both are branches of basilar that might be compressing the trigeminal nerve over here. That could be the reason. Case is trigeminal neuralgia. See the previous question also shingles. See the sensory supply of the face. 5th cranial nerve. Here also. So this trigeminal neuralgia is basically seen in V3 and V2, least in V1, very rarely in V1 involvement. V3, V2 are commonly involved over here. Okay, let's see one more. 28-year-old is admitted to the hospital for the evaluation of symmetric ascending weakness that started in his feet and has become progressively worse over the past 5 days. LP is performed to confirm diagnosis. As the needle is advanced during the procedure, there is resistance just before entering the epidural space, right? This resistance is most likely due to which of the following structures? Very good question. Ligamentum flavum, supra, interspinous, and durameter. Resistance is where? Just before entering the epidural space. Understand this. So LP, we all know lumbar puncture. For CSF on the lumbar system, vertebral level is normally taken around L4, L5 junction or L3, L4 junction. But what are the ligaments that are entered? See, starting from sequence is very important. Starting from skin or fascia, obviously the needle will go past it. And the first ligament that enters is the supraspinous. It is connecting the tip of the spinous process. After that, the next ligament it enters is the interspinous ligament between the edges of the spinous process. Then it enters the ligamentum flavum. Where is ligamentum flavum? Connecting the pedicles of the respective vertebrae. Then it reaches where? Then it reaches in the epidural space. Understand this. Then it has to go through the durameter. Again, resistance is felt over here also. Dura-arachnoid is sort of fused, then it reaches the subarachnoid space directly. And here is where the target structure is, that is the CSF is located over here. Sequence understand after skin fascia. Now what they are asking is, what resistance is felt before entering the epidural space? So before entering this space, the resistance is this ligamentum flavum. Resistance is also felt at durameter, but after, they are specifically asking before it enters the space above the dura, epidural space. Answer has to be the ligamentum flavum over here. Beautiful framed question, detailed of anatomy. So guys, that's the revision part. All the best, and I hope you enjoyed the session. Remember, don't just go through the question and answers and be happy. Go through the different topics. Whatever doubt you have, try to ask. These are very important high yield MCQs, and I wish you all the best. Few days left, so keep on revising and don't stop till you are clear with the exams. Thank you so much.